Okay, let's quickly cover carnitine deficiency. Now, before doing carnitine deficiency, you need to know about carnitine. What exactly is carnitine? So, quick recap. Now, carnitine, it acts like a taxi. Even the name is carnitine shuttle of this concept. Now, basically, what happens is that your fatty acid or long chain fatty acids, long chain fatty acids are converted to fatty acyl CoA. That is their activated form, and this is done with the help of a thiokinase. In other words, acyl CoA synthetase, which is there on the outer mitochondrial membrane. Now, once the fatty acyl CoA gets transported into the intermembranous space, there you get carnitine, which is working like a taxi. Now, what does it do? It separates CoA from fatty acyl and it binds to fatty acyl. Now, you have acyl carnitine here. And this is done with the help of this enzyme carnitine palmitoyl transferase 1 CPT-1, which is in the outer mitochondrial membrane. Now, thanks to this taxi, which was there to lend us a helping hand, and now your acyl is bound to carnitine and CoA dissociated. And why did this happen basically? CoA is unable to pass from the inner mitochondrial membrane. So imagine it in this manner that acyl did have the fatty acyl did have the ticket to cross this, but CoA forgot to buy the ticket. So therefore, CoA is unable to pass through inner mitochondrial membrane. And in order to tackle this problem, carnitine helped us a lot. So carnitine got bound with fatty acyl and you formed acyl carnitine, whereas CoA it stayed behind. Now carnitine helps us to cross this bridge and with the help of translocase. Now, once in the mitochondrial matrix, what happens is that you have carnitine palmitoyl transferase 2, which is CPT-II in the inner mitochondrial membrane. This is the second enzyme. Now, this acyl carnitine, it comes in contact with that, and again, the CoA binds the carnitine separates from fatty acyl, and fatty acyl gets binded to CoA once again. So you have a proper long chain fatty acyl CoA. So this is your carnitine shuttle. In cases of carnitine deficiency, what exactly happens? So you have two types of carnitine deficiencies. One is primary and the other is secondary. And before knowing even that, it is very important for you to know that how do you get carnitine? You get it from your diet. So in your diet, if you're consuming meat products or also in human milk, not exactly human milk, but milk in general, dairy products, you get a lot of carnitine from your diet. Other than that, amino acids such as lysine and methionine, even they help to synthesize carnitine. Now, what happens exactly is that carnitine is made in kidneys and liver, yes, but there should be some way for them to get transported into the cell. For that, you have this transport protein, which is called OCTN2, which is your organic cation transporter novel 2, right here. This is the protein or transporter protein which is going to help carnitine to be transported into the cell, right? So you need somehow some way in which it can be transported. So this is the carrier protein. Now, usually in the primary carnitine deficiency, what happens is that this protein it is mutated. There's some issue with this protein. So this protein won't be able to transport carnitine inwards. So therefore, any deficiency or any mutation in such sort of protein or in such sort of transporter, it results in primary carnitine deficiency. And what is the solution for it? What is its treatment? So primary carnitine deficiency, it is caused by defects in a membrane transporter protein that prevents the uptake of carnitine. So if there is obviously your body is unable to take up carnitine, so what are you going to do? The treatment is carnitine supplementation. There's nothing you can do other than giving even more carnitine to your body so that at least something happens. Then moving forward, secondary carnitine deficiency, what happens there? Now, in this primarily occurs as a result of defects in fatty acid oxidation. Now, here there's no problem with the transporter protein. Transport protein is working perfectly fine. Here, the transporter protein was problematic, therefore, this is genetic, and you from a young age itself, the person will know that yeah, they have this disease. Now, in secondary carnitine deficiencies, I've already mentioned there is some issue in the fatty acid oxidation. Because of this, there'll be accumulation of acyl carnitine. When acyl carnitine is accumulated, it will be excreted in urine. Therefore, there'll be very less carnitine available. Why? Because see, now beta oxidation is not happening, and acyl carnitine is already formed. But this acyl carnitine, since beta oxidation isn't happening, so this is like packed together. There's no way for it to dissociate because beta oxidation is not happening. So when acyl carnitine is being removed from the body where the kidneys and urine, so the entire acyl carnitine is removed, and even the taxi is removed. Even though the taxi, we have a very limited source of carnitine. Like we have very limited supply of carnitine, so we cannot afford losing carnitine as well. I mean, okay, if acyl wanted to go and be lost in urine, sure, go ahead, but not carnitine. Carnitine should have stayed behind. But anyways, because of this entire acyl carnitine thing, even carnitine got excreted in urine, and therefore we had a shortage of carnitine. Now, acquired secondary carnitine deficiency can be seen in patients with liver disease because, as I've told you, liver and kidneys they make carnitine. So, because of decreased carnitine synthesis, or those taking the anti-seizure drug, so people who are taking anti-seizure drugs such as valproic acid, even in them, you can see secondary carnitine deficiency. So, if they're questioning about primary, so primary, there's no second say in that. If there is problem with the transporter protein, this transporter protein, so there'll be primary carnitine deficiency. But if there's any other issue other than that, other than the transporter protein, so the issue will be, so the disease will be secondary carnitine deficiency. So let's look at this information right here. Carnitine deficiency. Carnitine deficiency is fatty acids cannot enter mitochondria, therefore there will be no beta oxidation and there will be no energy from the fats. And dietary deficiency is one of the causes, but this is rare because carnitine is abundant in your diet. And then liver disease could be one reason because carnitine is made in liver. Therefore, if liver is not making enough carnitine, so there'll be carnitine deficiency. Hemodialysis is one reason because in dialysis, the carnitine is removed from the body where the kidneys. Then genetic defects, especially in carnitine transporter, and also genetic defects in CPT-I and CPT-II enzymes. They're also they also cause carnitine deficiency. Now, see, out of all of these reasons, only this is the one that gets classified in primary carnitine deficiency. Rest all, including the CPT-I and CPT-II enzymes. So, any of the factors that are linked with the oxidation of fatty acid, they are, because there's some issue with the fatty acid oxidation, they all are going to be grouped in secondary carnitine deficiency. This carnitine transporter, if there's any defect in the carnitine transporter, OCTN2, which is organic cation transporter novel 2, so then it will be grouped as primary carnitine deficiency. What are the consequences? Obviously, if there's no carnitine, fatty acids will stay in the cytosol, they cannot be oxidized, there will be energy crisis. And already hypoketotic hypoglycemia. Hypoketosis because it's not oxidized. So when fatty acids get oxidized, what do you get? You get acetyl CoA, and then you get your what do you call it? Ketones. So there'll be no ketones. So therefore hypoketotic. And why hypoglycemia? Because body decides to use or decides to oxidize fatty acids when it's already in a in food deprived state, when it's already starving. So it's like, okay, we do not have glucose. Let's just go and ask help from fatty acids. But at this point, even fatty acids aren't helping. So hypoketotic and hypoglycemia because of already glucose shortage. And there'll be weakness and fatigue, there'll be liver dysfunction, there'll be cardiac myopathy, and yes. Now, primary and secondary, what's the difference between the two? Primary, the problem is with the carnitine itself, so with the transporter, right? So you'll have hypoketotic hypoglycemia, muscle weakness, cardiomyopathy. In secondary, carnitine is normal, but it gets used up, lost, and trapped, and the causes are because some sort of acidemias and toxins they bind with carnitine and they do not allow it to, they basically trap carnitine, right? Or fatty acid oxidation defects such as accumulation uses of carnitine, the same thing as I told you, acyl carnitine. So that's also one way of trapping carnitine. And liver or kidney disease, so there'll be no synthesis and there'll be loss. Because of kidney urine disease, there'll be because of both liver and kidney, both there'll be poor synthesis, but because of kidney disease there'll be excessive loss in urine. Valproate is the anti-seizure drug that will deplete carnitine. And this image you can see for the signs and symptoms as well, and the difference. So this genetic mutation affecting carnitine transporter, that's primary. And metabolic disorders disrupting carnitine synthesis because of liver disease and kidney disease. Absorption will be because of um, what could be the factors for absorption? Let's just go back and have a look. Absorption would be probably because of yes, these enzymes, or there could be other reasons as well. And then how about excretion? That's because of the kidney disease. And when you talk about CPT-I and CPT-II deficiencies, what happens there is that in CPT-I deficiency, this is liver form. Fatty acids cannot enter the liver mitochondria. In CPT-II, the fatty acids cannot enter the muscle mitochondria. And because they cannot enter liver mitochondria, so they'll be hypoketotic, hypoglycemia, and that's usually what's the trigger factor? Fasting. And the long chain fatty acids they remain in blood. Whereas in CPT-II deficiency, what happens is that there'll be muscle weakness, there'll be rhabdomyolysis because fatty acids cannot enter the muscle mitochondria, so there'll be very less ATP, and rhabdomyolysis, and there'll be myoglobinuria and myoglobinemia, so there'll be dark urine. Now you can look at this table. So CPT-I organ is liver, and CPT-II it's majorly in skeletal muscle. There'll be no fatty acid oxidation, therefore there'll be low ketones and hypoglycemia and hypoketotic. Here you'll have muscle energy failure, both of these are normal. And the trigger factor for this is fasting. For this, it is vigorous exercising, which leads to rhabdomyolysis. And yes, so that's about it.